So when you break your leg, you know to go to the emergency department. And when your father develops crushing chest pain while he's shoveling snow, you know to call 911. And when you wake up and you feel that cancerous lump in your neck, you know to get to your family doctor, who will arrange a biopsy and put you into an entire care system that makes sure that you get the appropriate treatment throughout your cancer journey. But what happens when you wake up with a sore joint? Is it because you played too much tennis yesterday? Or perhaps that old hockey injury is coming back to haunt you? But what if you get more than one joint? Are you just getting the flu? Or maybe it's just arthritis from aging, because that's normal, right? But for some people, it's not just a few joints. It becomes so many more, to the point where they can no longer get out of bed without help because they're so stiff in the mornings. And they have to wake up hours before their work start time because they need that time to loosen up so that they can get to the bus stop or even start typing at their desk. They have so much swelling in their hands that they can't pick up a coffee cup, and they can't dress themselves because their shoulders won't move. The energy is just gone from their bodies. The fatigue is so severe. And that's what it's like for 350,000 Canadians right now in Canada who are affected by rheumatoid arthritis. And so what do people do? Some of us will go to the internet to try to figure out what's wrong with us. Some of us can talk to our family members and realize, you need to go and have some assistance. And some of us know to go to our primary care physician. And if you're lucky, that physician can actually see you in a relatively short amount of time and knows to pick up the phone to call the rheumatologist and get you an appointment within a few weeks. That rheumatologist will see you, diagnose your rheumatoid arthritis, and get you onto the right treatment. And that treatment will take away that swelling, it'll take away that stiffness and inflammation. And you don't go on to get any joint damage, you continue doing everything you want and can do in your life. And that is the ideal situation. But it's not like that for everyone. This is what happens to some people with rheumatoid arthritis. And so I want you to imagine a different scenario here. The first is that so many people in your family and your community have rheumatoid arthritis that it's just normal to have it. It's not something that you're going to go and seek care for because it's what's expected to happen to you over time. Perhaps you already have so many medical conditions and so many other roles and responsibilities in your community that going to another appointment just does not fit in for you. Or you get to that primary care physician and you don't get examined and you don't get the right blood work done. You're just given opioids to control pain. Or perhaps you do make it through to that specialist appointment, but the specialist is incredibly rushed, doesn't explain what rheumatoid arthritis is, nor what the medications are meant to do. And so you take the prescription to the pharmacy, you receive a long list of potential side effects, and just decide that you can't risk those side effects because you have so many other things to do with your life. Or maybe you're able to navigate all of this and you do get onto those initial medications, but they stop working. And so your specialist says you need to go on to a better medication, and you go through all the steps that you need to get to that point, but then the government denies your claim for the medication. And that's the reality of rheumatoid arthritis for Indigenous peoples in Alberta, as well as in Canada right now. And so what we're going to talk about tonight is about how we change that story and some of the ways that we've changed the road to care for people. Now, in rheumatology, we've been so fortunate over the last 2 decades to have an explosion of medications available to treat rheumatoid arthritis. These medications have saved the health system and they've saved the social systems billions of dollars because we're able to stop inflammation at the joints. That means that the joints don't become damaged. People don't gain disability from their disease. These are the medications that let people like Phil Mickelson golf and Spencer O'Brien snowboard in the Olympics. It's truly amazing what these medications have given us in our toolbox. The other thing, though, is that we've learned how to use these medications in a much better way. And so in rheumatology, we call this concept treat to target. And there's 2 parts to treat to target. The first one is that we need to get people diagnosed early. So we know that if we can have treatment started within 12 weeks of that very first rheumatoid arthritis symptom, We can actually double the chances that you're going to go into a drug-free remission down the road, and we can increase your chances by 35% that you will not get any significant joint damage from your rheumatoid arthritis. The second piece of treat to target is actually how often we see people to follow up with them. So in the past, we wouldn't start treatment until it was very late. People were already in wheelchairs, or they were requiring a hospital admission to control their rheumatoid arthritis. We start things now very early, and we treat aggressively to try and control that inflammation. We're not happy to sit back and say, look, 6 months ago you had 10 swollen joints. Today you've only got 8. We're on the right track. We're doing great. We just don't accept these low benchmarks anymore. But when it comes to the Indigenous population with arthritis, the way that I feel we are working is still at a target to treat era. And why do I say this? So when I'm speaking with medical students or graduate students here at the school, we talk about how determinants of health are influencing rheumatoid arthritis outcomes for this population. What is a determinant of health? It's a really big concept to understand. It's all the things that are influencing your health, and they're determined by our social situations, our political and economic environments as well. They're things that are not easy for individuals to change on their own. So as an example, a determinant of health is genetics. And from the moment we're conceived, it is already in our DNA what types of cancers we're predisposed to be getting, or perhaps what neurodegenerative disorder we're going to get, or even what type of arthritis we might get. Another potential example is physical environments. We know that moving is healthy. What happens when you're in an environment that doesn't encourage physical activity? Well, health services are also another determinant of health. When you're able to access a provider and the resources that you need for health, you can have minor issues taken care of before they become major. Or you can also, if you have a condition that doesn't have a cure, get on the right treatment plan and the right treatment course. But there are inequities for determinants of health for Indigenous populations. When I ask the students about examples of how those might affect getting access to care, the students will give a very reasonable answer. If you can't get to a physician, how can you possibly get diagnosed? And that's completely correct. But there's other things that factor in. So let's talk about income and employment. If you're holding one of the very few jobs that are available in your community, and you have to start missing work to go to several appointments or go and get your investigations done so you can get an appointment, you're at risk for losing your occupation. There's a long line of people who are waiting to take that job, and so you may decide not to go. These things might seem very large and hard to understand, and so I think that's why sometimes we start to go back to that individual level. And what is it that the person could possibly do to help themselves? So the things I hear is, well, why can't they just help themselves? And so I'm going to take you on a bit of a journey just to understand about how there is a way that we can change things in society. So I'm going to ask everyone to just close their eyes for a moment. And it's okay to do, nothing bad will happen. Just close your eyes for a moment. And I want you to imagine your most memorable time out in the mountains. So think about what it's like to be there. And for me, it's a great way to exercise and get some physical activity, do some hiking, do some snowshoeing, something like that. It's also a great mental break. I get a chance to get away from work and just enjoy having that space. It can be very inspirational. The beauty of the nature is just incredible. So you have your spiritual experience there too. And then from an emotional aspect, you get time with your family or friends, and you get some space to breathe. And this is what health feels like. This is what well-being can be. And this is our goal. So I'll ask you all to open your eyes again. How did you get to the mountains today? And if you're like me, it's by a vehicle. So we all have choices when it comes to our own personal vehicle. It might be influenced by what our parents drove. It might be influenced by our needs, like how many kids we need to get into the vehicle or how much gear we're hauling. And it might even be related to our income. What could I afford to buy at the time? Or what sort of social situation am I trying to prove by having a fancy vehicle? But the thing we've all taken for granted is that there's actually roads to getting to the mountains. And so what happened to get those roads there? Well, there had to be a decision made that we're going to build a road. And someone at some point mapped out the exact great route to get there, taking into account the terrain and land acquisition and any sort of policies. And we also take for granted that those roads are going to be in good condition for us to navigate. We pay taxes so that the roads are cleared and they are in good working order. And we also expect that there will be police around who can help to make sure that people are following the rules of the road and no one is harmed by the lack of safety. So, what happens when that road was actually built with a really dangerous corner in it? So when we see this corner, we know that there's several people who've had accidents on it over time. And the vehicles that tend to roll over on this corner are those that have a high point of gravity. So are we going to tell people who have those types of vehicles, sorry, you're going to have to go buy a different vehicle. It's too dangerous to drive here. Or are we going to say, you know what, this road is closed to you. You're not allowed to come down it. You'll have to find a different route or maybe build your own road. Or are we going to look at it as a societal responsibility? We need to put in a guardrail so that people don't go over the edge. Or perhaps that we need to rebuild the route to make it safer for everybody. And this is the way it is with our healthcare system. We can actually work together to change that road to make it safe for everyone to navigate. So I'm going to now walk you through how we found those dangerous curves in the road in arthritis care, and also about how we've done some things to try and remedy that. So here on the screen is an arthritis toolkit, and it's been developed in consultation with hundreds of people who deal with arthritis, including patients and stakeholders in government across Canada. This is the map that patients can go to help decide how they might navigate inflammatory arthritis care. And it's also there for physicians to use as well. So where are the dangerous corners for Indigenous patients in this care map? Well, the first is simply at that step of being able to get to a primary care provider. In many communities, there is not adequate primary care. The second step might just be at that situation of being able to recognize inflammatory arthritis. Even though 1/5 of all primary care visits are related to musculoskeletal concerns, it is still very difficult to recognize inflammatory arthritis in those early stages of disease. And then from a very simple logistics point of view, getting between the referral being received and the patient being notified of their appointment. We still rely on phone calls and letters to let people know when they should come in. Well, what is it when there's not enough resource to actually have a permanent phone line? Then those calls are never received. Or we rely on a letter that goes to a mailbox that might be 90 kilometers from someone's home. And if they don't have the resource to get to their mailbox, they're not going to know that that appointment was there for them. So now let's talk about the things that we've done to change that road. So one of the things that my colleagues and I have done in Southern Alberta is to decentralize where care is given to Indigenous patients with arthritis. So we go out to the community, and it only makes logistical sense. We've got one person who goes out to see 40 or 50 people, as opposed to 40 or 50 people coming in to see one person. It's a very, very simple step, and patients appreciate that. But there's also so many more benefits to working in that way. So one of them is that the patients are in a place where they can celebrate their culture and be around the people who support them all the time. So in the waiting rooms, we hear Dene, we hear Blackfoot, we hear Stony. Those communities help to support each other. They look out for each other. And they're also there to be there when somebody needs to make a difficult decision about treatment or no treatment. We also get to see the things that help to build that resilience and that self-determination, all which are associated with improved health outcomes. It also makes so much sense to see what the situations people are experiencing are. So for example, when I give advice to go out and walk, I can see there are actually no sidewalks to walk on. So where is someone actually going to do that? And the other benefit is that I'm working alongside the family physician. So I'm actually appreciating what happens when they're receiving 12 specialist notes a day, all telling them to do so many different things for people, while also dealing with the concerns that are coming in on a daily basis. I can see them advocating for those patients and working really hard on those front lines. But they also get to work with me, and that's building inflammatory arthritis skill capacity as well. so that the next time someone comes in with a musculoskeletal complaint, that inflammatory arthritis can be recognized. Working in some of these communities, we also realized how silly it seemed that the patient was there with a concern, and I was there to see patients, and yet there was this whole process of having a referral go through and blood work and x-rays being done before I would see them. So we said, let's get rid of that. So we did 2 separate studies, one in a rural setting and one in an urban setting, to see what it would be like if we just removed those needs for referral. We saw about 250 people in a very short time span, of which 10% actually had a diagnosis of rheumatoid arthritis, but had stopped coming for care because of the negative experiences they'd had in our health system. We saw another 15% of people who had a new diagnosis of inflammatory arthritis, but had never been referred for their care. And so they were started on treatment as well. And all the rest of the people had musculoskeletal concerns that we could then offer the appropriate resources for. So that system worked. But there was still another thing that was wrong, and that was I was there 1 time a month. So what happens for someone on the other 29 days when they're still experiencing their arthritis symptoms and having new concerns arise? So what we've done is put in an arthritis liaison in the community who's there to be the connection between all of the different providers and help support the patient through. So certainly these changes are small. They need to start somewhere, and we need to scale them up and make them available to many more patients. But the arthritis clinic is not the only place where Indigenous patients come into contact with our healthcare system. Patients are coming into acute care, they're coming into chronic care, and we need to ensure that all the changes that we make are big and broad. So how do we get there? Because these changes do seem overwhelming. But fortunately, we already have a roadmap. The Truth and Reconciliation Commission of Canada has given us 94 things that we can start doing in society to improve relationships and to improve outcomes for health and so many other factors with Indigenous communities. There are 7 calls to action in health. I'll just list a few. Number 22, we need to improve the ability to offer traditional healing practices in our healthcare system to Indigenous patients who request them. So we have pockets where this happens, and they are excellent for patients, but we need to make these available to more people. Call number 23, we need more Indigenous healthcare providers in our system. The medical school is to be commended for the work it has done already to change how recruitment occurs and to improve the admissions process. But that's just the beginning of someone's medical career. There's an entire several years after that as they develop their skills and then launch their careers that we need to support them through. They have all the usual concerns and challenges that medical students have, but on top of that, they also have the responsibilities to their communities and their families that don't go away, and they're disconnected from those people when they're here training in our walls. So the steps that we need to make them now. And the reason is that it's from that place of societal responsibility. In large gatherings, we traditionally would acknowledge the land and the people who held the land before we were arriving here. And it's that responsibility that we have here as a medical school as well. So we honor our commitments to the Stoney Nakoda, the Blackfoot, and the Tsuut'ina Nations where our medical school is built. And we should be acting from a place of responsibility and also following the sacred teachings, a place of love. All Indigenous people with arthritis should have access to treat to target. And all Indigenous people also have the right to that basic human right to health. Thank you.